Welcome back to Human Physiology lectures. So we started looking at the circulatory system, and today we'll be discussing lecture 7 on the circulatory system. So here, mainly we are going to discuss the relationship between flow, pressure, and resistance in the vascular system. So at the end of this lecture, you should be able to know the following things that we are going to cover. So you should be able to understand the blood distribution and also the blood flow. Then we're also going to look at resistance and the circulatory shock. So at the end of this class, you should be able to describe these things that I've listed here. So without wasting much of the time, let's just go into the blood distribution. Okay, so about 60 to 64% of blood volume at rest is in the systemic, veins, and venules. So you know to say that within the veins and the venules, these are high compliance vessels. So they store large volumes of blood. So because they can store large volume of blood, the systemic veins and venules, they are also referred to as blood reservoirs. So they will function as blood reservoir. So these are the veins that are found under the skin and also within the abdominal organs like the liver and the spleen. So you find that within these veins, you have large volumes of blood that is stored in there. But if there is need for this blood to move to the other organs, you find that this blood can be diverted at time of need. So for instance, if there is an increase in muscle activities, you find that this blood now can be mobilized from the veins and then to go into the systemic circulation by the activity of the sympathetic stimulation. So when you have sympathetic stimulation, it will bring about vasoconstriction, and these veins will reduce in diameter because there will be more of vasoconstriction. Then the blood will return to the heart, and then it will be pumped to the systemic circulation so that it gets to the muscles. So when there is need for this blood, it can be mobilized from the systemic veins and venules that are functioning as blood reservoirs. And in terms of hemorrhage, that can also result into vasoconstriction to help maintain blood pressure. Because you know to say when there's hemorrhage, a person is losing blood, the blood pressure will be reducing. So we can have sympathetic stimulation that will bring about vasoconstriction, mobilizing this blood and then to be pumped into the systemic circulation. And you know to say once the cardiac output is increasing, the blood pressure is also increasing. So that is also involved in blood pressure regulation. So when you're talking of blood distribution, we say 60 to 64% of blood is found within the systemic veins and venules. Then about 13 to 15%, so you can see here, about 13 to 15% blood is found within the systemic arteries and arterioles. So in the systemic arteries and arterioles, they contain about 13% of blood. Then in the systemic capillaries, only 7% of blood. Then in the heart, within the heart, when a person is resting, there's only about 7% of blood. Then in the pulmonary vessels, there's about 9% of blood. So if you add these percentages, they're supposed to give you 100%. So you know to say that when a person is resting, much of the blood is found within the systemic veins and venules, then followed by the systemic arteries and arterioles, about 13%. Then you have pulmonary vessels, you're talking about pulmonary vein, pulmonary capillaries, and also pulmonary arteries. You're going to find 9% of total blood. Then the other 7% is found within the systemic capillaries and the other 7% in the heart. So this is just the normal distribution of blood when a person is resting. And the circulation of this blood, you know to say that first you need to start with the venous return. So blood that is drained from these organs, they are drained via the veins. So you have the venules and then you have the veins, the larger veins like the vena cava, the inferior vena cava and the superior vena cava, that is returning blood to the heart. So it will return to the heart via the right atrium. From the right atrium, the blood will be pumped into the pulmonary trunk. In the pulmonary trunk, you know to say that from the right atrium, of course, it will go into the right ventricle before it's pumped into the pulmonary trunk. So from the right ventricle, 100% of this blood is being pumped into the pulmonary trunk or the pulmonary artery that will now transport this blood to the lungs. So when blood is transported to the lungs, there will be oxygenation taking place here. This is where gaseous exchange is taking place. Then the blood will be oxygenated. Initially, it was deoxygenated blood, and then it will be oxygenated. So after oxygenation or gaseous exchange, you are losing carbon dioxide, you are gaining oxygen. So the oxygen is the one that is binding to the hemoglobin. Then this oxygenated blood now has to return back to the heart. So via the pulmonary vein, the oxygenated blood now will move to the left atrium. Then from the left atrium, this 100% of blood will move to the left ventricle. Then from the left ventricle, you know to say that during systole, when the ventricles are contracting, then the aortic semilunar valves are going to open and blood will be ejected into the aorta. Then from the aorta, blood will be distributed within the arterial system. So you can see if you have 100% of this cardiac output, about 3% of that blood is moving to the heart muscles, 5% to the bones, 6% to the skin, then 14%, which is much, it's going to the brain. So 14% of the cardiac output is going to the brain cells because you need oxygen, you need nutrients as well. Then about 15% is also going to the skeletal muscles. Then about 22% of the cardiac output is going to the kidneys. Remember, the kidneys are smaller. So these are small organs, but yet they are receiving more blood. So you know to say that the kidneys, they don't just necessarily need this blood for oxygenation, but they are also involved in excretion of waste products that are coming from the other tissues after metabolism. So they are involved in filtration of waste products and other things that needs to be eliminated from the body. So you find that the percentage of the cardiac output that is going to the kidneys, it's increased so that it's going to facilitate filtration of those metabolites. And about 21% is going to the gastrointestinal system in the spleen. And you know to say that the spleen is also functioning as a reservoir of blood, and it's also involved in immunity, the spleen. Then on top of that, you have the gastrointestinal system. So it's receiving about 21% of cardiac output. So this is also very important, is because this 21% of cardiac output is going to facilitate absorption of nutrients after digestion in the gastrointestinal tract system. Then this 20%, after it drains the GIT and the spleen, the blood will move to the liver. And on top of that, you can see here you have the hepatic portal vein that is receiving blood from the GIT. So this blood is rich in nutrients because this is after absorption. Then you also have the 6% that is coming from the arteries supplying the liver. So you have hepatic arteries that are supplying the liver, carrying about 6% of the cardiac output. Then the 6% plus the 21%, you find that the veins that are draining the liver will carry about 27% of the cardiac output because some of the blood is coming from the gastrointestinal system via the hepatic portal vein. Then the 8% is going just to other structures that are not mentioned here. So if you add these percentages, they're supposed to give you the 100% of the cardiac output. And then the same percentages are moving to the venous side. So you can see the percentages are correlating. So it will move to the venous side, and then the veins will be able now to transport this blood back to the heart. So this is just the blood flow. So here I just wanted you to appreciate the percentages of the cardiac output that is perfusing different organs of the body. But you can see that the kidneys and the gastrointestinal system, they have a higher percentage of the cardiac output. So that is needed because these systems, they don't just need the oxygen, but they also need to eliminate certain things. When you're talking of the kidneys and also the GIT, you need to absorb the nutrients. So you find that the percentage of the cardiac output is more to the kidneys and the gastrointestinal tract system, the accessory organ like the spleen, the GIT. So this is just the distribution of blood. So the movement of fluids from the cardiovascular system. So what you're looking at here, you have the arterial end or the arterial end of the capillaries and the venous end of the capillaries. So at the center here between the arterial system and the venous system, you have the capillaries. So these capillaries are smaller vessels that can just allow maybe a column of red blood cell to pass at a time because they are so tiny. So how does fluid move from the capillaries into the interstitial spaces? So there are these steering forces that will facilitate the movement of fluids. So you have the hydrostatic pressure due to the presence of water molecules in the cardiovascular system. You know to say there's plasma there. In plasma, you have water or fluids. So those water molecules will create hydrostatic pressure. So as you are moving from the arterial end to the venous end, you find that the hydrostatic pressure is more on the arterial end or the capillary. But on the venous end, the hydrostatic pressure is less. Then you also have choroid osmotic pressure. The choroid osmotic pressure or oncotic pressure is due to the presence of plasma proteins. So these plasma proteins, they also create a pressure. Why? It's because most of these proteins, they are charged, so they can attract water molecules. So they are going to create the colloid osmotic pressure or the oncotic pressure. So when you compare these two pressures, are the ones that are going to drive the movement of fluids, whether you're going to have filtration of the fluids or you're going to have absorption of the fluid. So on the arterial end of the capillary, you have a higher hydrostatic pressure as compared to oncotic pressure. So you can see the equation here. For you to know the movement of the fluids, you need to compare these forces. So the hydrostatic force and the oncotic pressure. So the hydrostatic pressure is greater within the arterial end. It's about 37 millimeter of mercury. But the oncotic pressure here is less. It's about 25. So if you add the forces that are facilitating the movement of fluids to the interstitial fluid minus the forces that are facilitating the movement of the fluids from the interstitial into the capillaries, then you have the net pressure. So the net pressure will be equal to the the hydrostatic pressure within the capillaries plus the oncotic pressure within the interstitial fluid. So the oncotic pressure within the interstitial fluid is almost zero because you don't have much proteins within the interstitial fluid. So because you don't have protein, you find that the oncotic pressure there is almost zero. So if you add 37 plus 0 minus the forces that are facilitating the movement of the fluids from the interstitial into the capillary on the arterial end of the capillary. So here you have two forces that will facilitate that movement. You have the oncotic pressure within the capillary. So you have capillary oncotic pressure, which is about 25, and the hydrostatic pressure within the interstitial. So this hydrostatic pressure within the interstitial is about 1. So if you get the difference of this, it's giving you 100 millimeter of mercury. This is just the net filtration pressure that is going to facilitate filtration of the fluids because it's a positive force. But when you move to the capillary end, to the venous end of the capillary, so this is the venous end of the capillary, you will find that you have less hydrostatic pressure here. So the hydrostatic pressure here is about 17. Then the oncotic pressure, as you are moving towards the capillaries, the oncotic pressure is going to increase so much. So you can see here that the hydrostatic pressure has reduced, but the oncotic pressure within the interstitial is still 0 because you don't have much of the proteins. Then you subtract the hydrostatic pressure within the fluid here. So the hydrostatic pressure in the capillary here, it has reduced to about 1, but the oncotic pressure is about 25. So you find that if you do your calculations here, you're going to get negative 9 millimeter of mercury. Because this force is negative, it's going to facilitate the movement of fluids back to the cardiovascular system. So it's called the net absorption pressure. So this is the net absorption pressure that is going to facilitate the movement of fluids from the interstitial back to the cardiovascular at the venous end of the capillary. So in simple terms, on the arterial end of the capillary, you have much of the pressure that is moving these fluids into the interstitial. So you're going to have the net filtration pressure, which is about 11. Certain textbooks will give you a value of 10. As you are moving towards the venous end of the capillary, you find that you have more of oncotic pressure as compared to hydrostatic pressure, because the hydrostatic pressure is reducing when you were losing fluids here. So it means that you're going to have more of oncotic pressure. So this oncotic pressure now is going to facilitate the movement of the fluids from the interstitial into the cardiovascular system, because this is a pressure that is created due to the presence of proteins that are going to attract water molecules. So this is what is going to facilitate movement of these fluids. So what you need to remember here is that the fluid that is being filtered from the arterial end of the capillaries, not all of this fluid is going to be absorbed back into the cardiovascular system. So there will be excess amount of fluid that will remain within the interstitial spaces. So this fluid that is remaining within the interstitial spaces is going to be drained by the lymphatic system. This is where the lymphatic system comes in. That's why the lymphatic system is also part of the circulatory system. So we'll discuss that in lecture 8. So just not to say that the excessive amount of fluid that is remaining within the interstitial will be drained by the lymphatics. That is the function of the lymphatic system. Moving on to blood flow. What is blood flow? Blood flow is simply the quantity of blood that passes a given point in the circulation per unit time. So it is measured in milliliters per minute. And this blood flow is direct proportional to the pressure gradient, and it's inversely proportional to the vascular resistance. So it means that if you have an increase in pressure gradient, you're going to have an increase in blood flow, which makes sense because the pressure is the one that is driving the blood flow. So if you have an increase in the pressure difference or the pressure gradient, it's going to increase the blood flow. But the resistance is inversely proportional to the blood flow. So it means if you have a decrease in vascular resistance, you're going to have an increase in blood flow. If you have an increase in vascular resistance, you're going to have a decrease in blood flow, which makes sense because the vascular resistance mainly is mainly maintained because of the radius or the diameter of the blood vessels. So the major factor of the resistance or the vascular resistance is the diameter or the radius of the blood vessels. So if the diameter is reducing in terms of venoconstriction or vasoconstriction in general, you find that the resistance will be increasing. If you have factors that will result into vasodilation, then you find that the resistance is going to be reducing. So these are the factors that are affecting the blood flow in simple terms. So flow in any portion of the vascular system is equal to the effective perfusion pressure in that portion divided by the resistance. So if you divide pressure gradient divided by the resistance, it will give you blood flow. In other ways, you can say effective perfusion pressure is the same pressure gradient. So this effective perfusion pressure to the tissues divided by the resistance, it will give you the blood flow to that tissue. So the effective perfusion pressure is the mean intraluminal pressure at the arterial end minus the mean pressure at the venous end. So you're talking of two ends, 2 points. So you have the arterial end and the venous end. So if you subtract the intraluminal pressure at the arterial end minus the venous end, it's going to give you the pressure difference I'm talking about. If you divide that by resistance, that is going to give you blood flow. So you can see in this example that you have a pipe here with blood that is moving within the pipe, and this pipe are blood vessels in the body. So you have 0.1 and 0.2. So if you know the pressure at 0.1 and you also know the pressure at 0.2, if you get the difference of these two pressures, it's going to give you the pressure gradient. But remember, blood is always moving from high pressure point to a low pressure point. So for this blood to move in this direction, it means that the pressure at P1 should be greater than the pressure at P2. So the difference in the pressure will give you the pressure gradient. Then the wall of this blood vessel is going to give you the resistance. And this resistance is mainly affected by the radius or the diameter of the blood vessel or the tube. So the equation for blood flow is analogous to Ohm's law. So you can compare it to Ohm's law. And you know to say Ohm's law looked at electricity. So you're talking of current. So current is equal to the electromotive force divided by the resistance. So in the same way, you can compare blood flow to current because the equation for the blood flow is equal to the pressure gradient or pressure divided by the resistance. So once I give you pressure and resistance, you'll be able to calculate blood flow to that particular organ. So when considering flow in a system of tubes, it is important to distinguish between velocity and flow. So there's a difference between velocity and flow. Velocity is the displacement per unit time, and flow is simply the volume per unit time. So these are two different things. Velocity is measured in centimeter per second because we're talking of displacement per unit time. So centimeter per second, flow is measured in centimeter cubed per second. So the velocity is proportional to the flow divided by the area of the conduit. You're talking of the cross-sectional area of the conduit in which the fluid is moving. So the velocity will be proportional to the flow divided by the area of the conduit. So it means this velocity is direct proportional to the flow, but it will be indirect proportional or inversely proportional to the cross-sectional area of the conduit or the pipe or the blood vessel. So you can see the formula for velocity. Velocity is equal to the flow of the fluid divided by the cross-sectional area of the conduit or the blood vessel. In other way, the blood flow can also be calculated as the velocity multiplied by the cross-sectional area. So it means that the blood flow is direct proportional to the velocity in the cross-sectional area of the conduit, which makes sense because if you're increasing the cross-sectional area of the conduit, then it means much of this fluid can move per unit time across that point because you have increased the surface area in which this fluid is passing. Then if you're also going to increase the velocity, it means much of this fluid is passing per unit time across a point. So it means once you increase the velocity or when you increase the cross-sectional area, then the blood flow is going to increase. But you shouldn't confuse the blood flow to blood pressure. So blood pressure is different from blood flow. When you're talking about blood pressure, is mainly the pressure that the blood is exiting on the wall of blood vessels. But blood flow, you're talking of the quantity of blood that is moving in a given point. So you have this point, how much blood is moving per unit time, then you're looking at the blood flow. But when you're talking of the pressure which this blood is exiting against the walls of the blood vessels, that's blood pressure. So it's different. So the velocity of the fluid at any point in the system depends not only on the area, but also on the flow. You're talking of blood flow in this case. And the flow in turn depends on the pressure gradient, properties of the fluid. Properties of the fluid, you're looking at maybe viscosity of the fluid and also the density of the fluid and also dimensions of the entire hydraulic system. So the dimensions of the entire hydraulic system, you're talking of radius and the diameter. So blood pressure, properties of the fluid, dimensions of the entire hydraulic system will have an effect on blood flow. So there is a relationship between resistance and blood flow. Let's look at laminar or streamline flow of blood. So laminar flow of blood or streamline flow of blood or fluids in general. So the flow of blood in the blood vessels, like the flow of liquids in narrow, rigid tubes, is normally laminar. So the flow of blood, it's laminar flow. So you know to say laminar flow is quite smooth. It doesn't produce sounds because this is stream flow of or streamline flow of blood within the blood vessels. So within the blood vessels, an infinitely thin layer of blood in contact with the wall of blood vessel does not move. So the blood that is closer to the wall of blood vessels or in contact with the wall of blood vessels, it doesn't move. But you find that the next layer within the vessel has a low velocity, and the next one will have a higher velocity, and the fourth one will have even a higher or greater velocity. So you find that the velocity of this blood column is greatest at the center of the stream. So this is called laminar flow of blood. So the laminar flow occurs at velocities up to a certain critical velocity. And this critical velocity is whereby when it reaches this critical velocity, the laminar flow will change and then to become more of turbulent flow. And this turbulent flow will produce sounds. So at or above this velocity, the flow is turbulent. But you know to say that the streamline flow is silent, but turbulent flow creates sounds because you have turbulent flow of blood, which is disorderly movement of blood, and then that will result into production of certain sounds. So this is the laminar flow of blood. It's always moving from high pressure to low pressure. So this is the movement of blood, or the flow of blood is always moving from high pressure to low pressure. So the blood, the column of blood that is in contact with the wall of the blood vessel is not moving at all. So you can see this cross-sectional that is showing the movement of blood. The column or the layer of blood that is contacting the wall of the blood vessel, the velocity is 0. It means it's not moving at all. As you move inwards, you find that the velocity will start increasing to the extent that the column of blood at the center of the lumen will have the highest velocity. So you have the maximum velocity, the blood particles or blood that is moving at the center of the stream will have the greatest velocity. As you move towards the wall of the blood vessel, the velocity will start decreasing to the extent that if you're looking at the blood column or the blood layer that is in contact with the wall of blood vessel is not moving at all. So this movement is laminar flow. So there are certain velocities. If the velocity has increased so much beyond the critical value, it will result into turbulent flow. And that turbulent flow will produce sounds. So the turbulent flow creates sounds, like I've already said. So the turbulent flow, blood flows in all directions in disorderly manner. So there is no order here. Blood is just moving. So blood flow, there is crosswise movement of blood flow forming wells, and these are called eddy currents. So the eddy currents is just disorderly movement of blood that will produce sound. So you can see here, if you have an obstruction to the blood vessel, As blood is coming here, maybe you can have laminar flow. As it's approaching the obstruction here, the velocity is going to increase because the lumen diameter has decreased here. So the velocity is going to increase. This an increase in velocity can result into turbulent flow of blood that will produce sound. So if you are using a stethoscope, you are able to get these sounds. This is the same when you're looking at measuring blood pressure using sphygmomanometer. We said you can get those clot cough sounds because when you occlude the brachial artery, as you are deflecting the calf pressure, when the brachial pressure is greater than the calf pressure, then blood will start moving. As blood is spurting through the brachial artery, it's moving at the greatest speed, and then this speed will produce clot cough sound. So this is the turbulent flow of blood that can create sounds. So the probability of turbulence is also related to the diameter of the vessel and the viscosity of the vessel. So this turbulence is related to the diameter of the vessel and the viscosity of the vessel. This probability can be expressed by the ratio of inertia to viscous forces. So in other way, the probability of turbulent flow is determined by the Reynolds number. So you have the Reynolds number. So the formula, the Reynolds number is equal to the inertial forces divided by viscous forces. So the inertial forces mainly is calculated as the density of the fluid multiplied by the mean velocity of the fluid, then multiplied by the pipe diameter or blood vessel diameter, divided by the dynamic viscosity of the fluid. So it means that the Reynolds number is direct proportional to the density of the fluid and the velocity of the fluid and also the diameter of the pipe or the blood vessel. But it's indirectly proportional to the viscosity of the blood vessels. So you can have laminar flow or turbulent flow depending on the Reynolds number. Okay. So under normal circumstances, if you have the Reynolds number of less than 2,100, you're going to have laminar flow. Then if the Reynolds number is between 2,100 and 4,000, then you're going to have a transition whereby the laminar flow now will change into turbulent flow. So anything greater than 4,000 of Reynolds number, you're going to have more of turbulent flow. So you can see the factors that are affecting the Reynolds number that is going to predict whether you're going to have laminar flow or turbulent flow. You have velocity. So you have this velocity. So if you have an increase in velocity, you're going to have an increase in Reynolds number, and that can result into turbulent flow. If you have an increase in characteristics dimensions, you're talking of the radius or the diameter of these blood vessels. So if you have an increase in the diameter or the radius of the blood vessels, you're going to have an increase in Reynolds number because the diameter is here. So this value will increase. If you have an increase in the density, so the density is here, then the Reynolds number is also going to increase. Remember, the Reynolds number is direct proportional to the density, the velocity, and the diameter, but it's inversely proportional to the viscosity. So if you have a decrease in viscosity, you're going to have an increase in Reynolds number. If you have an increase in viscosity, you're going to have a decrease. If you have an increase in viscosity, you're going to have a decrease in Reynolds number. If you have a decrease in viscosity, you're going to have an increase in Reynolds number. So there's a difference between density and viscosity. So when you're talking of density, this is the measure of space between two particles. So the space between two particles, that measure of space between two particles is called density. But viscosity is the parameter to measure the thickness or the thinness of any fluid. So when you talk of the thickness or the thinness of the fluid, that is viscosity. So if the thickness, if the fluid is becoming thicker, it means that the Reynolds number is going to reduce, because we said viscosity is inversely proportional to the Reynolds number. And the Reynolds number is the one that is going to predict the flow of fluids, whether you're going to have laminar flow or turbulent flow. So you can see here, if the Reynolds number is less than 2,100, then you're going to have laminar flow. If the Reynolds number is between 2,100 and 4,000, the flow is in transition. So now it's changing from laminar flow to more of turbulent flow. So if the Reynolds number is greater than 4,000, then here the velocity is so much that you're going to have turbulent flow that is going to produce or create sounds that you can get with a stethoscope. This diagram here is just showing you flow plotted against perfusion pressure. In this perfusion pressure is also giving you information about the velocity of the fluid. So you know to say if the perfusion pressure is increasing, then the flow will also increase. But if the perfusion pressure has increased so much beyond the critical Reynolds number, then it means that this laminar flow will change. It will be becoming more of turbulent flow. So looking at the Reynolds number, you'll be able to tell whether you're going to have laminar flow or turbulent flow of blood in blood vessels. So in humans, the critical velocity is sometimes exceeded in ascending aorta at the peak of systolic ejection. So during systole, you know to say that the blood pressure is going up, and the maximum pressure that you can get in arteries is referred to as systolic pressure. So if sometimes in humans, this systolic pressure can result into production of sounds, which are called turbulent flow of blood. So you can get murmurs as a result of abnormal flow of blood when the velocity has increased so much. But under normal circumstances, you find that in the arteries, they're just going to have laminar flow. But unless if there is something that is obstructing the flow of blood, when the arteries are constricted, you can have turbulent flow that can produce sounds. So turbulence occurs more frequently in anemia because the viscosity of blood is lower. So you know to say in anemia, you have less blood or less blood cells. So in anemia, the viscosity is going to decrease. So if the viscosity is reducing, you know to say the Reynolds number is going to increase because the Reynolds number is inversely proportional to the viscosity. So if the viscosity is decreasing, in an example given here in anemia you have less blood cells, then the viscosity is decreasing, then the Reynolds number is going to increase, chances of having turbulence is going to increase. So this may be the explanation of the systolic murmurs that are common in anemia. So in anemia, you can get systolic murmurs that are produced due to turbulent flow of blood when the viscosity has reduced. The flow tends to become turbulent when the flow velocity is high. So when the flow velocity is high, you know to say turbulent can take place because the Reynolds number is going to increase. Remember the formula, we say that the Reynolds number is equal to the density multiplied by the velocity multiplied by the diameter divided by the viscosity of the fluid. So if the velocity is increasing, then you can have turbulent flow. If the velocity is increasing, turbulent flow. If the fluid viscosity is also reducing, then you can have turbulent flow because it's inversely proportional to Reynolds number that will predict the turbulence. Then if you have a fluid density which is greater, so the density, if the density is increasing, the Reynolds number is going to increase. Then the tube diameter is large. When it's large here, it means the Reynolds number is going to increase. Then also the wall of the vessel when it's irregular. So when the wall of the vessel is irregular, that will bring about constriction of the blood vessels that can also produce turbulent flow. So these are the factors that are affecting the flow of blood, whether you're going to have laminar flow or turbulent flow. But mainly, you need to look at the Reynolds number. If the Reynolds number is less than 2,100, then you're having more of laminar flow. Anything above that, you're going to have a transition between 2,100 and 4,000, you're going to have a transition. Anything greater than 4,000, then you're going to have turbulent flow. So we move on to the relationship between pressure, flow, and resistance. So what is the relationship between pressure, flow, and resistance? But before we discuss that, just some information on the resistance. So the resistance is the force that opposes the flow of a fluid. So the force that is opposing the flow of the fluid is called resistance. Remember, resistance is mainly affected by the diameter or the radius of the blood vessels. If the diameter of blood vessels is increasing, then resistance is reducing. Blood flow is going to increase. If the diameter or the radius of blood vessels is decreasing, the resistance is going to increase, then blood flow is going to reduce. But blood pressure can increase. So you need to understand these dynamics of the cardiovascular system. So in the blood vessel, most of the resistance is due to vessel diameter. So the vessel diameter is the one that is controlling the resistance. So if the diameter is decreasing, the resistance will increase in simple terms. And you know to say, when you're looking at this resistance, I told you to say the blood vessels that will provide the greatest resistance are the smaller arteries and arterioles, because the lumen diameter is so small. So they are going to provide resistance to the blood flow. So at smaller arteries and arterioles, this is where you have a drop in blood pressure. So you can see in this diagram that in the larger arteries, the blood pressure is maintained between 80 and 120 on average. So it's between 120 and 80. 80 is the diastolic volume, the diastolic pressure, which is the lowest pressure, and 120 is the systolic pressure, which is the maximum pressure in the arteries. But as you are moving to the smaller arteries and arterioles, you can see that the blood pressure is decreasing so much. Why? It's because they're going to provide the greatest resistance to the blood flow. So you can even see the pressure is dropping to almost zero. So the resistance is directly proportional to the length of the vessel and to the viscosity of the blood. So the formula for resistance is equal to the length of blood vessel multiplied by the viscosity divided by the radius raised to the power 4. So it means resistance is directly proportional to the length of blood vessel and the viscosity, but it's inversely proportional to the radius or the diameter of the blood vessel. So if you have an increase in the length of blood vessel, the resistance is going to increase. If you have an increase in viscosity, the resistance is also going to increase. But if you have an increase in the radius, the resistance is going to decrease. So you need to understand these factors that are affecting the resistance. So resistance is affected by the length, the viscosity, and the radius. But the major factor is the radius, because you know to say that the radius is raised to the power 4. So if you're going to double the radius, for instance, it means 2 to the power 4 is going to give you 16. It means that your resistance is going to decrease by a factor of 16. But if you're going to double the length, then your resistance is just going to increase by 2. If you're going to double the viscosity of the fluid, the resistance is going to increase by a factor of 2. But if you just double the radius, you find that the resistance is going to decrease by a factor of 16. In other way, if you decrease the radius, the resistance is going to increase so much. So the major factor that is affecting resistance is the radius of blood vessel. So this radius of blood vessel will have more effect on the resistance. So the most fundamental law that governs the flow of fluids through the cylindrical tubes was derived empirically by the French physiologist by the name of Poiseuille. So Poiseuille is the one that looked at the relationship between pressure, flow, and resistance. So his work was so precise and important that his observation have been designated Poiseuille's law. So there is Poiseuille's law that governs the relationship between pressure, flow, and resistance. So the relationship between the flow in the long, narrow tube, the viscosity of the fluid, and the radius of the tube is expressed mathematically in Poiseuille's Hagen formula. So I want you to understand this Poiseuille's Hagen formula. So the Poiseuille's Hagen formula is also derived from the flow equation. Remember, we said velocity is equal to blood flow or flow divided by the cross-section area. So it means that flow will be equal to cross-sectional area of the tube or the blood vessel multiplied by the velocity. This equation can also be expressed in terms of Ohm's law of the fluids. So the Ohm's law of the fluids states that the flow of the fluid is equal to the pressure gradient divided by resistance. And you know to say the formula for resistance is equal to 8 multiplied by the viscosity multiplied by the length of the blood vessel or the tube divided by pi r raised to the power 4. So this is the formula for resistance. You can simplify this by dividing area squared, because you know to say pi r squared, it's area, but you have pi r raised to the power 4. So you have area multiplied by another area. So it's the same as expressing it as area raised to the power 4. So if we are saying that the resistance is equal to 8 multiplied by the viscosity multiplied by the length divided by pi r raised to the power 4, if you substitute resistance, these variables here in this equation, so it means your blood flow will be equal to the change in pressure multiplied by the equation for resistance. You know to say, if resistance, you're putting it down here, it means that you're going to multiply it with pi r raised to the power 4 divided by 8 multiplied by the viscosity and the length. So you know to say that here there is a swap in variables because you are dividing with the resistance. So if you put these variables down here, how are you going to simplify this equation? Is by multiplying the denominator with pi r raised to the power 4 and the numerator multiplied by pi r raised to the power 4. So it means that the blood flow will be equal to the change in pressure divided by multiplied by the pi r raised to the power 4 divided by 8 multiplied by the viscosity and the length. So this equation is called Poiseuille's equation or Poiseuille's Hagen equation. So the Poiseuille's Hagen equation is equal to, so blood flow or flow of fluid is equal to the pi multiplied by, so the pi multiplied by the pressure gradient. So you are subtracting pressure at point 1 minus pressure at point 2. It's going to give you the pressure gradient, then multiplied by r raised to the power 4. So the radius raised to the power 4 divided by 8 multiplied by viscosity multiplied by the length. So these are the factors that are affecting the blood flow. So you know to say blood flow is direct proportional to the radius and the pressure gradient, but it's inversely proportional to the viscosity and the length of the blood vessel or the pipe. So once I give you some questions, they could be true or false questions. If you know this equation, then you'll be able to know, because sometimes I can ask you to say, when you have an increase in viscosity, that will result into an increase in blood flow, true or false. So that becomes false. Why? It's because viscosity is inversely proportional to the blood flow. So you need to remember this Poiseuille's equation. So this Poiseuille's equation is looking at resistance, blood flow, and blood pressure. So this is the relationship between blood pressure, blood flow, and the resistance to the flow of blood. Then there's also law of Laplace. So the law of Laplace states that tension in the wall of the cylindrical, so the tension in the wall of the cylinder is equal to the product of transmural pressure and the radius divided by the wall thickness. So this is law of Laplace. So this law states that the tension in the wall of the cylinder is equal to the product of transmural pressure and the radius divided by the wall thickness. So it means that this law of Laplace is directly proportional. So this tension, you know to say this tension is direct proportional to the transmural pressure in the radius, but it's inversely proportional to the wall thickness. So this is the equation for law of Laplace. So the equation states that the tension on the surface of blood vessels, so this tension on the surface of blood vessels is equal to the transmural pressure across the wall of blood vessels, the transmural pressure multiplied by the radius of these blood vessels divided by the thickness of blood vessels. So this law of Laplace is very important for you to understand why capillaries do not rupture. Because you know to say that blood pressure is so high, it's about 120 systolic pressure. The systolic pressure is about 80. This pressure is so high that if it gets to the capillaries, you know to say the capillaries is just one layer vessel. So one layer is a single cell layer vessel that is so weak to the extent that this pressure can actually result into rupturing of capillaries. But the capillaries do not rupture. Why? It's because of the law of Laplace. The first thing you need to know to say, as blood is moving via the smaller arteries and arterioles, the blood pressure will reduce so much to almost zero. So that is going to protect the capillaries. At the same time, you know to say that the transmural pressure, this tension here is equal to the transmural pressure multiplied by the radius divided by the wall. So in capillaries, the wall is negligible because the thickness of the wall of capillaries is macroscopic. You can't even see it with your naked eyes. So because of that, you find that the pressure that is exerted by the blood to the capillaries is not that much because of the law of Laplace. You know to say that this tension is pressure multiplied by the radius divided by the thickness. So in capillaries, the thickness is almost zero in terms of the thickness, and then also the radius is so small, is reduced, so you don't have much tension across the wall of the capillaries that is going to protect the wall of the capillaries. So it is perhaps surprising that the structures as thin-walled and delicate as capillaries are not more prone to rupture. So in thin-walled structures, the wall of the capillaries, which is W, is very small and can be ignored. But it becomes a significant factor in vessel or blood vessels such as the arteries, because the thickness is so big, because you have those 3 layers. So the last part of this lecture, we'll be looking at the circulatory shock. So let's start. So the circulatory shock is a condition of generalized cardiovascular failure characterized by insufficient organ blood flow that is often accompanied by hypotension. So in simple terms, hypotension is the one that is going to result into circulatory shock, because you're going to have insufficient organ blood flow. So the perfusion to the organs is going to reduce. Because the perfusion to the organs is reducing, it means that oxygen supply to the tissues is reducing. That can result into ischemia, and at the same time you have necrosis that can start within the tissues, because there's no oxygen that is reaching the tissues, and you know to say you need oxygen for you to have metabolism. So without this oxygen, metabolism will stop, you have less ATP, and then you can have ischemia and necrosis. So the circulatory shock mainly is due to hypotension. So in other way, the circulatory shock is accompanied by hypotension. So this is the state in which profound and widespread reduction of the effective perfusion leads to the first to the reversible, and then if prolonged, irreversible cellular damage. So you're going to have cellular damage. So this circulatory shock is a condition that is progressive. So it will start as mild, then it becomes moderate, then it can become severe, depending on the factors that are involved in this circulatory shock. So sometimes you can have stages of shock whereby it's reversible with intervention. And then sometimes it can just be reversible by those mechanisms that are controlling blood pressure, regulation mechanisms. But sometimes if things are so bad that the regulatory mechanism, they are unable to regulate the blood pressure, it's reducing so much, then you find you need intervention. Then if you delay to intervene, sometimes you find that it goes into the irreversible state, in which even if you do anything, there is nothing that can be done. That person is going to die. So those are certain stages of circulatory shock that we're going to discuss maybe in the next slide. So the classification based on cardiovascular characteristics, which was initially proposed in 1971 by Hinshaw and Cox. So the Hinshaw and Cox, these are the scientists that were just describing the classification of circulatory shock. So you have 4 different types of circulatory shock. We have hypovolemic shock that looks at low in circulating volume. So if you have low blood volume, for instance, that can result into hypovolemic shock. Then you have cardiogenic shock, poor pumping function. You're looking at the contractility and also the pumping action of the heart itself. So if there's abnormal pumping action of the heart, it can result into cardiogenic shock. Then you can also have obstructive, that results into obstruction of blood flow. So if you have an emboli, you have cancer, that will result into obstruction of blood vessels. It can result into obstructive shock. Then the last type of shock is called distributive or vasogenic shock, an increased blood vessel capacitance. So if you have an increased blood vessel capacitance due to maybe vasodilators, it can result into distributive shock. So maybe you can have more blood on the venous side as compared to the arterial side. That can also result into circulatory shock. and this is because of distributive dysfunction. So it's called distributive or vasogenic shock. So these are 4 different types of shock that are also summarized in this table or diagram. So you have circulatory shock, the different types of circulatory shock, the 4 different types of circulatory shock, and the subtypes of these circulatory shocks. So you have 4 major types of circulatory shock. So hypovolemic shock, vasogenic shock, which is also called distributive shock. Then you have cardiogenic shock and obstructive shock. The hypovolemic shock, you can have hemorrhagic shock when you're losing blood to the outside or maybe into the internal cavities of the body due to trauma or hemorrhage or whatever it is. So you can have hemorrhagic shock, you can have traumatic shock due to trauma. Then you can also have surgical shock, maybe after surgery, you are cutting some blood vessels that can also result into shock. So you can have surgical shock or Baines shock. So Baines shock, mainly when you are looking at 3rd-degree Baines, you find that a person will be dehydrated because via the veins you can lose a lot of blood, a lot of fluids. So as you're losing fluids, so it's a special type of hypovolemic shock because the volume, blood volume or plasma volume is going to decrease. And then in case of dehydration, you can have dehydration shock also. That will result into hypovolemic shock. So hemorrhage, trauma, surgical, pain, and dehydration can result into hypovolemic shock. Then vasogenic shock or distributive shock, we have different subtypes here. You can have neurogenic shock due to neurostimulation or dysfunction of the neurons, mainly the autonomic nervous system. For instance, if you have a reduced autonomic tone, you find that you are producing less catecholamines that can result into a vasogenic shock sometimes. And then you can have anaphylactic shock due to allergic reactions. So you can have severe allergic reactions that can result into anaphylactic shock because some of the toxins during this reaction can be vasodilators. For instance, histamine, that will bring about vasodilatation, and then the permeability will increase. And then you find that you can have edema that can also result into shock. Septic shock is as a result of infection. So it can be a viral infection, bacterial infection, rickettsial infections, or whatever it is, that can also result into shock. So these are called distributive or vasogenic shock associated with the blood vessels. Then you have shock that is associated with the heart itself. It's called cardiogenic shock. So examples of cardiogenic shock, you can have shock due to arrhythmias. So you can have bradycardia or tachycardia. That will result into a decrease in cardiac output, blood pressure will reduce, and then that can result into cardiogenic shock. Shock due to ischemia. If you have less blood supply to a tissue, the tissue will become ischemic. Then necrosis can set in, they'll start producing certain chemicals that can also result into cardiogenic shock. Then shock due to heart failure. Sometimes when you have heart failure, the cardiac output will be less because the contractility of the heart muscles are compromised or dysfunctional. So that can also result into shock. Then the last type of shock, which is called obstructive shock. So here you can have shock due to myocardial tumor. So you can have myocardial cancers or tumors that can result into a shock that is affecting the myocardium itself. So even the pumping of this myocardium is compromised. Then you can have shock due to cardiac tamponade. Cardiac tamponade is where you have infiltration of fluids into the pericardial cavity. And this fluid is going to compress the heart. So you find that during diastole, the heart doesn't feel well with blood. So the end diastolic volume is going to reduce, the stroke volume is going to reduce, cardiac output is going to reduce, then the blood pressure will reduce. That can also result into obstructive shock because of that obstruction of the fluid that is accumulating within the pericardial cavity. Then you can also have shock due to pulmonary vascular obstruction. So if you have pulmonary vascular obstruction, it could be the pulmonary arteries where you have embolism there, or pulmonary embolism, So that emboli can obstruct or occlude blood vessels, and then the movement of blood can be compromised there. Then you can have accumulation of blood within maybe the right atrium that is not moving to the left atrium. And then if blood is not moving to the left atrium, there's less blood for the ventricles, the left ventricle to pump into the systemic circulation, and that will result into reduction in cardiac output. Then it can result into shock. And this type of shock is due to obstruction. So it's called obstructive shock. So these are different types of circulatory shock. Okay, so just a bit of information on each shock, but we won't really discuss much because this is not pathology, this is physiology. So I will just highlight some of these conditions that can result into hypovolemic shock, cardiogenic shock, or other different types of shock. So the hypovolemic shock, from the name itself, hypo, it means lower than normal. Volemic, this is the volume. So a hypovolemic shock is a shock that will result due to low blood volume. So there are factors that can cause low blood volume. So this hypovolemic shock is also called orogenic. So the orogenic simply means a condition in which total blood volume is reduced. So orogenic, it means the total blood volume is reduced. So simply pointing to hypovolemic shock. That can be due to hemorrhagic or hemorrhage. Hemorrhagic can be due to trauma, gastrointestinal, maybe peptic ulcers that is resulting into hemorrhage, then retroperitoneal. So you can have bleeding in the retroperitoneal, you're losing blood into the peritoneal cavity. That can also result into hypovolemic shock because the blood volume will be reducing. Then you can also have hypovolemic shock due to fluid depletion. So fluid depletion, this is called non-hemorrhagic shock. So there is no hemorrhage there. So it's due to fluid loss. So you can have external fluid loss in terms of dehydration, vomiting, diarrhea, polyuria. So all these, you are losing fluids, body fluids, the blood volume will reduce. Not that the blood cells are reduced, but the plasma will reduce. So these are also called non-hemorrhagic shock. Then you can also have interstitial fluid redistribution in case of thermal injury. So if you have thermal injury, temperature injury, or trauma or anaphylaxis, you can have interstitial fluid redistribution that will result into hypovolemic shock. Then increased vascular capacitance. When you have venous dilatation, when there is venous dilatation, it means that the veins are increasing in diameter. That will store more blood. So you find that the percentage of blood that is stored due to venous dilatation, it will be greater than 64% of total blood. So you find that it can increase to 80%, and that can also result into hypovolemic shock because on the arterial side, you have less blood. And that can be due to sepsis when there is infection, anaphylaxis, allergic reactions, toxins, and certain drugs that can result into an increase in vascular capacitance. Okay, so that was hypovolemic shock. Moving on to vasogenic or distributive shock. So distributive or vasogenic shock. So here you have different types. So you have septic due to bacterial infection, fungal, viral, or rickettsial. So these can cause septic shock. So there's production of toxins. So you can have toxic shock syndrome because of these infections. You find that the body cells will start producing certain products that can be toxic, and it will result into septic shock. You can have anaphylactic shock or anaphylactoid shock due to allergic reactions, of course. Then there's also neurogenic type of distributive or vasogenic shock. So the neurogenic, you can have spinal shock whereby you have reduced autonomic tone. If you have reduced autonomic tone, it means you're producing less of norepinephrine and norepinephrine. That will result into the blood vessels becoming more of dilated. So they will be dilated to the extent that blood will be, there will be less blood that is going in circulation because of the vasodilatation. So that will also result into shock. So because it's the dysfunction of the nervous system, then it's called neurogenic or spinal shock. Then you can also have endocrinologic shock. So the endocrinologic shock is due to the endocrine system. In this case, you can have adrenal crisis. The adrenal crisis, you know, to say the adrenal gland is producing a lot of hormones, you have cortisol, you have catecholamines. So when you have adrenal crisis, you are reducing the production of catecholamines, you are also reducing the production of cortisol. So if you have reduction in cortisol, that can result into vomiting, fever, and also blood pressure is going to decrease. Then you're going to have more of vasogenic type of circulatory shock or the distributive type of circulatory shock. Then toxics, of course, there are certain toxins that can result into distributive or vasogenic shock because they will have these toxins, they will have an effect on blood vessels. That's why it's called vasogenic. So you have toxins, for instance, nitro peroxide. So the nitro peroxide or beryllium. So nitro peroxide and beryllium toxins, all these can result into distributive or vasogenic shock. Cardiogenic shock, it can be due to myopathy or myopathic. So this myopathic, you can have myocardial infarction, the left ventricular myocardial infarction or right ventricular myocardial infarction. You can have myocardial contusions or due to trauma, myocarditis, inflammation of the myocardium, cardiomyopathy. You can also have post-ischemic myocardial staining, then septic myocardial depression, pharmacological due to drugs. You have anthracycline, cardiotoxicity, calcium channel blockers that can result into reduction in the contractility of the myocardium. That will decrease the cardiac output and blood pressure will also reduce. That will result into cardiogenic shock. Then you also have mechanical causes of cardiogenic shock. You have valvular failure, like regurgitation of the valves, obstruction of the valves in terms of stenosis, then blood flow will reduce. So you find that even if the ventricles are contracting, blood can be ejected into the pulmonary trunk and also the aorta because of stenosis or obstruction of the valves or diseases that are affecting the valves. Then hypotropic cardiomyopathy, ventricular septal defects, when you have opening or certain holes that will allow communication of the right part of the heart and the left side of the heart, that will result into decrease in blood pressures, and then that can result into cardiogenic shock. Then arrhythmias, of course, bradycardia, tachycardia, these can also result into cardiogenic shock. So in bradycardia, you can have sinus bradycardia, which is called vagal syncope. So if you have vagal stimulation, is going to inhibit the firing of the SA node, that can result into reduced heart rate, reduced cardiac output, and blood flow to the brain will reduce, and then these people can faint. So it's called a vagal syncope. Then you can have atrioventricular blocks. So these are AV blocks that will reduce also the heart rate and can result into low blood pressure. Then you have cardiogenic shock. Tachycardia, you can have supraventricular tachycardia or ventricular tachycardia. So if the heart rate has increased so much to the extent that it's not allowing ample time for filling the ventricles, you'll find that overall the filling time is reducing. At the same time, the end diastolic volume is going to reduce, the stroke volume is going to reduce, the cardiac output will reduce, the blood pressure will reduce, and that can also result into shock, cardiogenic shock. Then the last type is called extracardiogenic obstructive shock. due to impaired diastolic filling, so decreased ventricular preload. So if you have a decrease in ventricular preload, you know to say the stroke volume is going to decrease, and the venous and also the cardiac output is going to decrease. So you can have direct venous obstruction. In case of vena cava, you can have intrathoracic obstructive tumors, the tumors that are developing within the thoracic cavity that will now be compressing the veins and also the heart. Increased intrathoracic pressure. If you have an increased intrathoracic pressure, is putting more pressure on those vena cava, the inferior superior vena cava. So you have reduced compliance of the vena cavas or an increase in terms of resistance. Then you can have tension pneumothorax. In tension pneumothorax, if you injure yourself, especially the rib cage, you can pierce, maybe the rib cage is pierced with a pin, or it could be a nail, to the extent that the intrapleural pressure is opened. So air will start moving into the pleural pressure, into the pleural cavity. So when air is moving into the pleural cavity, the intrapleural pressure is going to increase, and then that can also result into pressing of the vena cavas, the inferior and superior vena cava, and pushing the heart towards the left side of the body or to the right side of the body, depending where the injury has taken place. And that can also result into reduced venous return, because the veins are not really open, so they are compressed. So the resistance has increased and the venous return will decrease. And also, if that is taking place within the aorta, you find that the cardiac output is also going to decrease. Case of asthma, then also decreased cardiac compliance in constrictive pericarditis, in cardiac tamponade, like I've already explained. You can have acute cases, chronic cases, idiopathic, where you don't know the cause. Then you can also have impaired systolic contraction, where you're going to have increased ventricular afterload. So the resistance is increased here now. So all these will result into obstructive. So there is obstruction. So this obstruction will result into decrease in cardiac output. Blood pressure will decrease, and blood flow is also going to decrease. That will result into circulatory shock. So there are 3 stages of shock. So there is non-progressive or compensated shock. So the compensatory mechanism causes full recovery without help from outside therapy. So even without intervention here, the person is going to recover, because this is non-progressive. So those regulatory mechanisms that are regulating blood pressure, they are enough to restore the blood pressure within the normal ranges. So you're not going to have shock. Then you have the progressive shock. The progressive shock, it means without therapy, the shock becomes steadily worse until death. So it means when the shock is becoming progressive, then intervention is necessary. Without intervention, it will progress into irreversible shock. So the irreversible shock has progressed to such an extent that all forms of non-therapy are inadequate to save the person's life. So once shock progresses into the irreversible state, it means nothing can be done. This person will just die. So it will start as non-progressive shock, then it will progress, then later on it becomes irreversible shock. So within the progressive stage, with intervention, you are able to resuscitate this person, or you are able to help the patient to go back to the normal blood pressures and also to take care of the shock. But if the progressive stage, nothing has been done within the progressive stage, it's going to progress into the irreversible shock. Once it reaches this state, even if you do blood transfusion, nothing will happen. You find that this blood will be just lost somehow, and then the patient will die. So before it becomes irreversible, then you need to intervene at the point where you're having progressive stage of shock. The pathophysiology of shock. So if you have a decreased cardiac output due to different reasons, of which you know the factors that are affecting the cardiac output. So if you have those factors that are reducing the cardiac output, so if you have the decreased cardiac output, that will result into decreased arterial pressure, then it will result into decreased systemic blood flow. This will mean that you're going to have decreased cardiac nutrition because there's less blood that is going to the cardiac muscle cells. So you're going to have decreased cardiac nutrition. At the same time, you're going to have decreased nutrition of the tissue, and also you're going to have intravascular clotting. You can have DIC, disseminated intravascular coagulopathies, whereby you can have blood clotting taking place in most of these blood vessels. So it's disseminated intravascular coagulopathy. So once you have these things taking place, it will result into decreased nutrition of the vascular system. So once you have decreased nutrition of the vascular system, that will result into increased capillary permeability because of the vasodilators. That will result into decreased blood volume. Then you have decreased venous return. At the same time, this will result into a decrease in cardiac output because the venous return is decreasing. At the same time, you have decreased nutrition of the brain, and then decreased vasomotor activity, the vascular dilation because you don't have the sympathetic stimulation as a result of decreased vasomotor activity. The venous pooling of blood will take place. So you find that there will be more blood that will be now accumulating within the venous side of the circulatory system. That will result into decreased venous return. Then the cardiac output will decrease more. Then you can have tissue ischemia, then the release of toxins, and these toxins will cause cardiac depression. Then the patient can actually die because the cardiac output will decrease even more as a result of these mechanisms. So it means before these things happen, or before they become severe, then you need those regulatory mechanisms to come in to regulate the blood pressure. Or if it's moving to progressive stage, intervention is needed. If you don't intervene, then it will move to irreversible stage, where even if you do something, nothing will be done. Then the compensated shock. This is a progressive stage. The compensated shock, when you have acute loss of less than 10% of total blood. If a person loses about 10% of blood or less than 10%, there are those mechanisms that will kick in to regulate blood pressure. Because you know to say you're losing blood due to hemorrhage or whatever it is, there will be a decreased venous return because the blood volume has decreased. So venous return is going to decrease. There will be decreased cardiac output. Then there will be decreased blood pressure. That will result into the compensatory mechanisms. So once you have decreased blood pressure, this will be your stimulus now to activate the compensatory mechanism. That's why this stage is called compensated shock. So once you have this minor shock, the compensatory mechanisms that will kick in here are baroreceptor mechanisms. You know to say within the carotid sinus and the aortic arc, you have those baroreceptors that can respond to pressure changes. So with decrease in blood pressure, it means that the firing of the baroreceptor will reduce, and then the nucleus of tractus solitarius will be stimulated via the cranial nerve number 10, the vagus nerve, and the cranial nerve number 9, which is the glossopharyngeal nerve. So once the firing of action potentials is reducing, the nucleus of tractus solitarius in the medulla oblongata is going to activate the cardio acceleratory centers, and then it's going to inhibit the cardio inhibitory centers, and then at the same time is going to stimulate the vasomotor center within the medulla oblongata. So the blood vessels, they will be constricting because there will be release of norepinephrine by the sympathetics. At the same time, via the vagus nerve, you find that there's also inhibition of the vagus nerve, so it's not producing acetylcholine, but the sympathetics is producing more of norepinephrine that is stimulating the SA nodes, and also the AV node. So the firing of action potential is increasing, then the heart rate is going to increase. So it will bring about tachycardia. In this tachycardia, it will increase the cardiac output, then it will increase the blood pressure. Once you have an increase in cardiac output, blood pressure is going to increase. Then on the same time, you find that these baroreceptors is also resulting into vasoconstriction because of the sympathetic stimulation. If you have vasoconstriction, it means that venous return is increasing, the total peripheral resistance is also increasing, the blood pressure is going to increase. The renin-aldosterone system, so this is the renin-angiotensin-aldosterone system that is also going to be activated to regulate the blood pressure. So we say that within the kidneys, you have the production of renin when you have low blood pressure. So this renin in circulation, you know to say it's coming from the juxtaglomerular apparatus produced by the granular cells, and the renin is going to convert angiotensinogen into angiotensin 2, angiotensin 1. Then the angiotensin 1 will be converted into angiotensin 2 by the angiotensin converting enzyme within the lungs and also the kidneys. There are those endothelial cells that are producing the angiotensin converting enzyme that will convert angiotensin 1 into angiotensin 2. The angiotensin 2 has got a lot of functions. An increase in angiotensin 2, it can go and stimulate the adrenal cortex to release aldosterone. The aldosterone will go to the kidney nephron to stimulate the reabsorption of sodium and chloride. Then that will be followed by reabsorption of water. So you have water and sodium retention because of aldosterone. Then when water is reabsorbed, there will be an increase in blood volume and also an increase in cardiac output. At the same time, this compensatory mechanism will also result into more production of ADH. Even the angiotensin 2 can also stimulate the posterior pituitary gland to release more of ADH, and this ADH is also called vasopressin. So it will go and cause vasoconstriction, and at the same time, it will go to the kidneys to stimulate the translocation or to stimulate the production of aquaporins 2 and also translocation of aquaporins 2. That will be inserted within the apical membrane of the epithelium cells in the kidney nephron. That will result into absorption of or reabsorption of water molecules into the epithelium cells, and then via the aquaporins 3, it will be reabsorbed into the interstitial. Then the blood volume will increase. The blood pressure is also going to increase. So these are the compensatory mechanisms. Then if these compensatory mechanisms are not enough, then this shock is going to proceed to progressive shock. So you have now the progressive shock. The progressive shock is due to loss of 10%, between 10 and 15%. So an acute loss of 10 to 15% of total blood volume. So if you're losing between 10 to 15%, you're going to have severe reduction in venous return because blood volume is reducing. There will be severe reduction in cardiac output that will bring about severe decrease in blood pressure. So this severe decrease in blood pressure, those compensatory mechanisms are not enough to bring it to the normal range. So you can see once you have severe decrease in blood pressure, it will result into severe myocardial ischemia, release of toxins from damaged cardiac tissue or myocardium. And then these toxins, it will result into further deterioration in the cardiac function. That will bring about a decrease in cardiac output again because the myocardium are not functioning well. They are being damaged. There is a lot of deterioration of the cardiac muscle cells. At the same time, the severe decrease in blood pressure, it will result into suppression of vasomotor center within the medulla oblongata. That will bring about severe vasodilatation because now you don't have the sympathetics. There is no release of those epinephrine and epinephrine. So you're going to have more of vasodilatation or vasodilatation if you want. That will result into further decrease in blood pressure. Then you have thrombus formation in the capillaries. So if you have a decrease in blood pressure, and then the blood flow is going to decrease, and then the tendency of thrombi to form is going to increase. So you have thrombus that are going to form within the capillaries, and then obstruction in the capillary blood flow, because you know to say the capillaries are so small. So if you have clots taking place there due to DIC, then you have obstruction. Once you have obstruction, there's going to be an increase in capillary hydrostatic pressure because blood is not moving. So the accumulation of blood within the capillaries, it will result into an increase in capillary hydrostatic pressure. Then you start losing the plasma into the interstitial. That will result now into fluid diffusion into the interstitial spaces, and then you have deterioration of other tissues now. So you need to intervene here to reverse this effect of progressive shock. Otherwise, if no intervention is done, then it will proceed into the irreversible shock. So the irreversible shock is when you have acute loss of more than 15% of total blood. So if you have hemorrhage and then you're losing 15% of your total blood, it will result into irreversible shock. So what will happen here? So first, you're going to have decreased coronary blood flow because you have decrease in blood volume. Then you are going to have myocardial ischemia, damage to the myocardium because they are not receiving sufficient oxygen. That will result into cardiac failure. Once there is cardiac failure, there is drastic decrease in cardiac output. That will result into drastic fall in blood pressure. And when you have this drastic fall of blood pressure, that will result into death of the patient as a result of irreversible shock. Then you also have decreased cerebral blood flow. So the blood that is the blood supply to the brain is decreased because you have decrease in blood volume. That will result into cerebral ischemia. That can also result into shock because there is damage to the neuronal cells of the brain. So you have failure of the vasomotor center. There is generalized vasodilatation because you don't have sympathetic stimulation. That will result into pooling of blood in the veins. So this pooling of blood in the veins will result into decreased venous return. Decreased venous return, you're going to have drastic decrease in cardiac output. That will result into drastic fall in blood pressure, then death of the patient. Then the other mechanism due to blood loss, if you lose about 15% of total blood, you find that there will be continuous sympathetic discharge here. This continuous sympathetic discharge is a compensatory mechanism because it's trying to compensate for the blood loss that is resulting into reduced blood pressure. So you're going to have continuous sympathetic discharge that will result into constriction of the venules and precapillary sphincter muscles. Then you're going to have reduced venous blood flow because you have the constriction of the venules and also the precapillary sphincter. So blood is not moving from the arterial system to the venous system. That will result into reduced venous blood flow, then failure to wash out metabolites. So if blood is not moving from the arterial side to the venous side, there is accumulation of metabolites within the tissues, and some of these metabolites are toxic. So there is release of vasodilators that will bring about dilatation of the veins, which won't be enough. So if you have dilatation of the veins, it will result into decrease in venous return, then drastic decrease in cardiac output, drastic fall in blood pressure that will also result into death. So this is the irreversible shock. Even if you do blood transfusion, you have so many toxins and you have a lot of reaction that is taking place here, so it can't be compensated. So once it reaches this stage, then there is no going back. The end result is death. So you have the organ system dysfunction in shock. So at your own time, you can check this table. So you can see the organs that are failing due to shock. You have the central nervous system that is failing. The heart is also failing. The pulmonary is also failing, the kidneys, the gastrointestinal tract system is failing, the liver is failing, hematologic or the bones that are involved in hematopoiesis, so they are also failing. Metabolic, you have accumulation of these metabolites that will result into losing of blood volume, because now you have an increase in the permeability of the capillaries and also an increase in terms of dilatation of the veins. So you find that the blood pressure will decrease even more. Then the immune system is also involved, because now you're going to have generalized activation of the immune system that will bring about the other cellular damage or other cellular immune system depression and moral immune depression. So you find that infections, now you can't fight the infections because the immune system is somehow dysfunctional, or there is depression of the immune system. So those barriers that are supposed to protect the body are no longer there. So you find that the bacteria now will hammer you to result into septicemia, and then finally the person is going to die because now you have generalized organ failure. So the organs will start failing. Okay, so this is it. Thank you very much for your time. This is where I end this lecture.